So, thanks for joining us again for another episode of the EMS Handoff Podcast. You may have seen David on the intro, but there's a couple of things that I just want to point out. So, right now it is the 13th of October, and David is not actually with us on the podcast tonight because he's been working for the last 14 days or so in the EOC in Tennessee. Unfortunately, the western half of North Carolina, some of Georgia, some of South Carolina, and a portion of the eastern part of Tennessee have been devastated by a hurricane with lots of damage and a couple of things that hopefully we'll never see again in our lifetime. But unfortunately, between David, myself, Joe, who's going to be with us tonight, we've seen hurricanes over the last 20 years, and we've all had our hands in disaster response. So our thoughts and prayers are with everybody in the affected areas, including the Florida, who just recently had another hurricane that went through right across the panhandle of Florida. So with that being said, tonight we're joined by Joe Slattery. I'm going to tell you a little bit about him, but I'm really going to turn it over to him and let him introduce himself. So he's got a bachelor's degree in Homeland Security and Emergency Management, and is dual certified healthcare simulation educator, and has a huge background in EMS and EMS simulation, and has a lot of projects, a lot of stuff that he's working on. So, Joe, thank you for joining us tonight. I'm going to turn it over to you and kind of let you do a little bit more introduction and your background with healthcare simulation.
Okay. Well, thank you, Bradley. Thank you for having me here, and let me follow up on your sentiment. Let's pray for all of the people affected by both of these hurricanes. Two devastating hurricanes in a matter of 2 weeks. Our EMS crews are definitely being taxed at the moment. So all of our prayers for them. So I got my start in EMS back in 1992 up in New Jersey. Worked for 19 years in various different levels of EMT, back when EMTA stood for EMT ambulance, not advanced EMT. Became a paramedic about 13 years ago and started immediately working in simulation. When I became a paramedic, I was working for a hospital system in New Jersey. You and I spent a little bit of time working together when I was working with Durham County EMS in North Carolina. I left there to go to Mercer University School of Medicine, where I was teaching medical students and residents of Memorial Hospital. And now I'm building 4 simulation labs in East Florida for HCA hospitals. And I'm also working on some projects. I'm working on a lecture that I'm giving in Georgia and Texas this month, or I'm sorry, Georgia and Connecticut this month, on safety in healthcare simulation. Which is one of my big, strong topics that I really like to talk about, and hopefully we can get into a little bit of that this evening.
So let's talk just a little bit about simulation in healthcare. A lot of us have been doing stuff for, the last, 15, 20 years as we've been teaching classes and doing stuff, and some even longer. I can remember even prior to that, in the late 90s, when I went through class, I mean, sometimes these instructors would just give us scenarios and you sit back and you scratch your head. I mean, when we talk about, scope of practice and wanted to test students, it was kind of funny, and I will never forget one of the scenarios was, so you've got a kid that climbs a tree. It's an October day. The kid climbs a tree. The tree limb breaks, and he's in the northern part of the U.S., so he falls into a cold pond, and as he climbs out of the pond beside the tree that he fell into, he disturbs a yellow jacket's nest. So he's got a fractured leg, he's hypothermic, and a bee sting. What were we doing to these students?
We thought we were making them stronger. I will say that. We really thought that by giving them these crazy scenarios, we were teaching them how to think critically, and we were teaching them that they could handle anything. And we were wrong. I mean, let's just be honest. We were 100% in the wrong. We were teaching our students how to be afraid of education, how to be afraid to learn something new. Because every time that they saw us, we gave them crazy, crazy scenarios that were completely unwinnable. And we never once thought we should just give them a softball. We should just, here, you have a kid who fell out of a tree. What do you want to do? Right? We want to put them on a backboard. We want to immobilize them. We want to do a full assessment. We want to get them in a warm space and make them trauma naked and take them to the trauma center. Yay, you won the scenario. But we couldn't do that. We had to make it 3 different scenarios in one. And the problem was what we've learned over the course of the last 15 years, and mostly through the Society for Simulation in Healthcare, who has been a huge proponent for simulation. What we've learned is we need to validate scenarios. We need to give scenarios that are clinically appropriate. They can be difficult scenarios, but they have to be clinically appropriate. Now, is it possible that you're going to have a kid one day who fell out of a tree into a cold pond and disturbed a yellow jacket's nest? Maybe. We'll put it under the realm of it could happen. But if we don't train on the kid who fell out of a tree and the kid who fell in the cold pond and the kid who stumbled upon a yellow jacket's nest independently, then we're just failing ourselves as a profession.
So those scenarios, I mean, like we just said, they were leading students down the wrong path. They were teaching them to be afraid of what we were doing.
Mm-hmm.
And, then they were like, well, somebody's got to lead the scenario, and nobody wanted to do it.
Right.
So let's talk a little bit about scenario development and validation, because you and I have had multiple discussions before, and then even some offline discussions about we've got to make sure that we identify what we're trying to test, what the student's been taught, and then develop the scenario around that objective.
Right.
So let's talk about that.
So absolutely. So the first thing is basic principles of learning. We introduce something new. We give the learners time to practice something new. And then at some point we test them to make sure that they're competent on something new. Right? That's basically what happens from the day we enter pre-K all the way through when we graduate, right? EMS, for some reason, we just decide, here's something new, let's throw you to the wolves and see if you can handle it. But we don't put much thought into that practice time or into how we're going to test them. So you brought up a good point, and clearly the thing that we need to do before we do any kind of scenario development is we need to identify our objectives for the scenario. Okay. It doesn't matter what the objectives are. And the objectives, and we'll go back to your, kid that fell out of a tree and into the cold pond. The objectives of that scenario could be, how do we manage a hypothermic trauma patient with an anaphylactic reaction? Okay, but would we want to create a scenario like that? We have to think about as we're going through. The key to it, though, is that we have to first identify what are we testing for. Okay. Here's a thought. Since we're talking about the objectives of the scenario, why don't you and I put together a scenario really quickly, and we can talk about objectives. Okay. So let's go back a couple of years. Let's make this. We'll keep it kind of simple for the purpose of the podcast, or else we could be here all night. But let's say we're rolling out albuterol to our EMT basics. And our EMT basics are going to start giving albuterol. It's now in the state protocol. I'm dating myself a little bit, but we'll just go with something simple. So what do we have to do? We have to teach them about the drug, the indications, contraindications, uses, dosing, etc. We have to teach them how to assemble a nebulizer. We have to teach them how to squirt the albuterol into the nebulizer or dose it from a multi-dose vial. And then we have to teach them how to set the oxygen settings. and they need to be between 5 and 8 liters per minute for it to mist appropriately. Okay. So we hold a training session. We show them how to do all of these. Maybe we do it in a couple different stations, whatever the case. Then we give them time to practice it. Now we're going to create a scenario, and this scenario would be considered a summative scenario, which means an exam. So there's two types of scenarios, formative and summative. Formative would be a scenario to help them learn how to practice it with a patient. And then summative would be an exam. Okay. So in this summative scenario, what are our objectives? So you tell me, what do you want the student to accomplish at the end of this exam? And I would say, okay, using that example, we would want them to be able to successfully assemble a nebulizer and administer 2.5 liters or 2.5 milligrams, it's been a minute, of albuterol. Okay, that's the objective. All right, that's our whole objective for our simple scenario. Okay, so now let's talk about our patient. Who would we give albuterol to? An asthmatic and potentially somebody with pneumonia. But for our EMTs, since it's a basic scenario and it's a basic platform, our EMTs can give it to a patient with a known history of asthma. Okay. So what would their lung sounds be? What do you think?
They're going to have wheezing.
Okay. They're going to have wheezing. Could they have bronchi?
They certainly could if it was pneumonia.
Okay. But for our EMTs, they would have to have wheezing.
Right.
Okay. For our paramedics, they could have bronchi.
Correct.
Okay. So now our objectives have changed a little bit depending on whether it's an EMT scenario or a paramedic scenario. Okay. All right. So let's say we have a patient who is 30 years old, has a history of asthma, is wheezing, and has an empty inhaler. Okay. What if I now give you that same patient and I add in that the patient has rails? What if they have peripheral edema?
Now we're heading down another pathway.
Right. So if we were to test the scenario using a competent EMT, what do you think that test subject would do?
They would say this patient doesn't have the signs and symptoms of asthma. They've got something else.
Okay, so they would now use critical thinking skills to determine whether or not albuterol was the right treatment for that patient. And would it be safe to say that a competent EMT would not give albuterol to that patient?
I don't know. I thought we had competent paramedics, but I still find them giving albuterol to CHF patients. But anyway, that's
Okay.
a side point.
Well, let's see if we can test that out of them. Let's see if we can fix that. But maybe so. Well, the reason I'm bringing it up is maybe BiPAP or CPAP is the right answer, and albuterol is not the right answer. But we changed the parameters and we changed the objectives of the scenario. If we go back to our original objective, which was we want to see them assemble and administer correctly 2.5 milligrams of albuterol. Well, now we've given them a scenario where they have to critically decide, is albuterol the correct medication? So we built a scenario that did not meet the objectives of what we were trying to attain. And I think that's the pitfall that we run into over and over again. And in some cases, and I don't want to throw anybody, under the bus, so to speak, but I think we've seen it enough times that we have that one EMT who comes through, walks in the door, listens to lung sounds, and within a minute of being with the patient has the albuterol set up and ready to go. Well, that scenario is too easy. So, as the educator, what am I going to add to this scenario to make it more difficult for that person? And when we do that, we throw the objectives out the window and we give that one person a completely different scenario. Maybe we throw some Strider into it. And you're like, okay, well, we know that asthma is a lower airway problem and Stridor's an upper airway problem. So why are we making this one EMT work harder? And why are we invalidating the scenario that we created that we already know works? The way we fall into that pitfall is we don't build the scenario from the objectives up, and we don't stick to the objectives when we build them. We do what's called in simulation building scenarios on the fly. And that is a big no-no. But we've been doing it for years, right? You've seen it, I've seen it. It's kind of funny. There's a firefighter paramedic who does a whole series of YouTube videos, and I use one of his videos. He talks about national registry scenarios, and you walk in the door and the patient doesn't feel well, and you're there for 2 seconds, and the guy says, "Your patient's dead. He had a katana sword sticking out of his back that you missed in your assessment." And you're like, how could anybody know that? Because there's no objective to that scenario other than to make you feel bad. So that's step number one. I don't want to prolong that at all, but step number one absolutely is define your objectives. Step number two is build your scenario to meet the objectives. So what do you want? Do you want to throw something in on that, or you want me to keep going the way I'm going here?
No, I think we're headed the right direction. So build the scenario to meet the objectives and make sure that they're smart objectives, because we've got to have a timeline on these scenarios as well. If somebody meets the objective 2 minutes into the scenario, great, they win. Okay.
Right.
Let's
for some reason we can't let them win.
Yeah. We should not build scenarios that people fail because we want them to fail. We should build scenarios that people fail because they don't pay attention to the object or to the scenario and all the clues.
Right. And we don't need to add clues into a scenario to throw the person off. We don't need to, we don't need those outliers. We don't well, I'm going to say most of the time we don't need them. Now, the more your people and your agency, if you're watching this, the more your people do with simulation, the more complex your simulations can get, because they get very good and they get very comfortable doing simulations. And you'll see that as administration or as the education team, because they'll be calling you, asking you, when's the next simulation? When do they get to do it again? And once you know that they want to do it again, now you've got an engaged group of people who have been given scenarios that are clinically appropriate, objective-driven scenarios, and they want more. And then you can start to get complex in the scenarios, right? We can then talk about that CHF-COPD patient, but we're changing the objectives of, now let's critically think about, what are we treating for? Are we treating for the COPD side, or are we treating for the CHF side? When you have somebody who's first starting out, you've got to keep those objectives straightforward, right? You can't build something and ask somebody to put together an albuterol if they don't have a patient who needs albuterol, right? It's just, and then you can't belittle that person, or you can't come after them and say, well, you failed the scenario. No, the fact of the matter is the scenario failed them. And we as the education team failed them. So that leads us into the second part that I want to really spend a little bit of time on. We have to test scenarios. Scenarios have to be written, they have to be reviewed, and they have to be tested. Who do we test them on? Not our medical director, because they know the answers, right? We know that they know the answers.
But we want them to review them.
We want them to review them to make sure that we are clinically appropriate.
Right.
Absolutely 100%. Right. Now, that can be a struggle too, because our medical directors want to embellish scenarios a little bit sometimes as well. And as the educator, we have to take a step back and say, okay, but is that appropriate to meet our objectives? And if we're hard and fast on meeting our objectives, their review should meet our objectives. Okay. So then who do we test it on? Well, we could share interagency. I could call you up and say, Bradley, I just wrote a new scenario. Can you run this through with a couple of your EMTs and tell me how it works? Right. But the key to that is then when you test the scenario, you have to let your people know that they are testing the scenario. The scenario is not testing them. They have absolutely no repercussions if they don't meet the objectives of the scenario that I build. That's my fault, not theirs. So we have to. That's part of my safety piece of it is psychologically they have to know that they're coming in to test a exam tool to find out if the exam tool meets the objectives that I wanted it to meet. But we could easily share, and I'm probably saying a bad word if any of my friends from New Jersey ever hear this. Share between agencies? Why would we do that? We know more than they do. Anyway, I'll stop there. But the key here is we have to make sure the testing tool works. How do we do it? We test it on a group of people. Maybe we have a couple of EMTs who are on light duty. They're not going to be going through their regular process, or we have a couple of EMTs who've already been through the process, and now we get to test a new scenario on them. They're a great test bunch because we know that they're competent. So would a competent person make these right decisions? I think that's absolutely paramount if we're going to be using simulation as a testing tool.
So let's talk a little bit about difficulty.
Okay.
So we write the scenario for the objective. We test the scenario. Once we test the scenario, we work toward the validation, but we also need to look at that scenario because we may have a group of people that it needs to be very simple for, but we also may have a group of people that we're working with that are advanced and it can make a little bit more complex.
And that's the next big piece of the puzzle because it depends on why we're running a simulation. If we're doing a simulation for our annual competencies, right? We're running a cardiology scenario for our annual competencies. In that scenario, we should be using things like Scarbosa's criterias, left bundle branch blocks, things that we don't see every day. Because the goal here is we're testing people that we know are competent, but we want to refresh them on some kind of relatively difficult case. So if I were to give you a patient who was a 62-year-old female with complaints of back pain and nausea, and she describes the back pain as dull, right? We don't want to have a tearing back pain because that would throw us down a different path. And then we look at her and say, okay, well, she's 62 years old. Our job requires us to do a 12-lead EKG, and that 12-lead reveals a left bundle branch block. And we question the patient, has your doctor ever said anything to you about a left bundle branch block before? No. Okay, so we potentially have a new left bundle branch block. We should probably work this patient up for an MI and call in and see if they want to activate the cath lab. Right? That would be a complex scenario, but it still meets the objectives of our annual competency for cardiology. Right? We could level that as a difficult scenario, much more difficult than a 65-year-old male with crushing chest pain who's cold, pale, diaphoretic, has a little bit of nausea, his left arm hurts, and you see 4 millimeter ST segment elevations in lead 2, right? So those two scenarios, one for somebody who's doing annual competencies, that the second one that I gave you, really easy and straightforward. The first one that I gave you, a lot more complex, requires a little bit more critical thinking. but do they both meet the objectives of we want to call the cath lab? And that's the idea. Now, we could do something even more simple, and it works around some of the new tools that we have. Okay, video laryngoscopes, all the rage about 5 or 6 years ago, right? Everybody started carrying video laryngoscopes. How do we test on them? Well, we follow the same thing, the same logic of we introduce it, we give them time to practice, and then we test. Do we need to do a complex scenario to test it, or could we do a very simple, straightforward scenario? You have a patient in respiratory arrest. They need to be intubated. Assemble your video, assemble your equipment, and go ahead and successfully intubate the patient. Right? That it could be a very straightforward, simple test, because we're not testing at this point whether or not they know that they need to intubate the patient. We're testing them on the use of the equipment. It comes back to our objectives, right? If we have a group of people who are unsuccessful, maybe we want to put them through different types of scenarios where we run a scenario where we're testing them to see if they want to intubate the patient. And if they want to intubate the patient, that they should go ahead and do it. That would be a much more complex.
Yep.
Go ahead.
So could a scenario have two branches? One, if they elect to manage it with a blind insertion airway device, that is perfectly fine.
Mhm.
Or if they decide to intubate, it's perfectly fine. And then we branch off here if it goes right main stem or left, or appropriate, so forth and so on.
Okay.
Can we do that in scenarios?
We can, but the objective of the scenario is to successfully manage the airway.
Right.
Okay. So if we go all the way back to the beginning and we say we're going to give our team a scenario where the whole focus and the whole objective of the scenario is to effectively manage this patient's airway and take them to the hospital. Is a blind insertion device effective? Absolutely. Is an endotracheal tube effective? Absolutely. Is one better than the other? Depends on who you talk to, right? But if we create a scenario with the objective of we want the patient to intubate, or we want the team to intubate the patient, if they choose to put in a blind insertion device, then they did not meet the objectives of the scenario. And we have to go back and look, did we give them the correct parameters that we wanted them to follow? Okay. And how we could do that, depending on whether it's a formative or summative, one way that we could do that is they could put in a blind insertion device, and the person ventilating, we can tell them they're not getting chest rise. What would we do if we put in a blind insertion device that's not adequately, or it's not giving us a proper CO2 reading? Ideally, we should set up the intubation equipment and pull the blind insertion device. So we could build that into the scenario as well. But we could absolutely build the scenario to go down two different pathways. But those are scenarios where we're talking about testing them on their critical thinking abilities, not on their physical procedure skills, if that makes sense to you.
Yes.
Okay. So again, come back to the objective. What do we want them to do? With my chest pain and my non-chest pain patient, do we want them to take the patient to the cath lab? Do both of those scenarios work? Yes, one is more difficult, one is easier. And then with our airway management, we have to accept that if we tell them that the objective was to manage the airway successfully, then we have to accept however they manage the airway. If it was successful, they won the scenario. We can't turn around and say, well, you were supposed to intubate, but you put in an iGel, if our scenario was for them to successfully manage the airway. And that's a lot of times where our education team goes off the rails as well, because they were like, well, we wanted you to intubate, but you built a scenario that said manage the airway. So you go ahead.
So with that, so when we bring the participant in? Should we tell them what the objective is, or just give them the scenario and let them?
We should give them the scenario. So, well, first things first, we should tell them what the stakes are involved,
Okay.
right? So everybody should know when they go into a simulation what is going to happen at the end of this simulation, right? This is a simulation where we're testing new equipment. If you're successful with the new equipment, you're allowed to use it in the field. Okay. If you're not successful, you'll come back tomorrow. We'll do it again. Okay. Um, if you're building something like a clinical clearance scenario where they've been through an academy and now this is their final exam before they're allowed to go into the field, they need to know what happens if all they need to know is what happens if they pass the exam and what happens if they fail the exam.
Right.
These are usually run as a full-on patient scenario, so they would be given dispatch information only. Okay. When they enter the room, they would then have to learn for themselves what they would do to treat this patient. And if they are competent, what they would do to treat the patient is what we designed for them to do in the scenario. But we would not give them, you're expected to manage this patient's airway. We would tell them, you are called to an unconscious patient, or you're called to a difficulty breathing, right? And they would figure it out just like it would be on a call.
So, we talked about having the objective, how to test and validate the scenario, talk about leveling a little bit for difficulty. So, let's say that I'm your student. So I'm going to come in and you're going to give me either a formative or actually, let's just say it's a summative scenario.
Okay.
All along, we have had throughout class a little bit of practice with mannequins and a few other things. I have not seen. So I'm going to stop right there for just a second. I'm going to talk about a couple of terminology that just kind of bugs me. Let's talk about high fidelity, medium fidelity, and low fidelity for a minute.
Sure.
I think, or I believe, that the industry, the people selling the mannequins, use that terminology to describe the mannequin when really that's not what it is. You can have the mannequin that sits up in the bed, talks to you, pukes all over you. Fidelity, high fidelity, is the experience that the learner gets. If you got somebody who can't run that mannequin, that's a low fidelity simulation.
Say that again for the people in the back.
Okay. But if you got somebody who can work that mannequin and the scenario as designed, then that's high fidelity.
Right.
I
it doesn't matter how many bells and whistles the thing has. If they can't use it.
Yeah. I can take Fred the head, do a few things with him, and give the learner a medium to high fidelity simulation off of Fred. Fred the head was made before you and I ever got started. Okay.
And he still works.
He still works.
Yeah.
So
no, you're absolutely right. Yeah.
I don't care if you've got a $150,000 mannequin. If you can't use it, it's not worth it. So now let's talk about the learner that has never seen, because sometimes, colleges do not want them touching any of these mannequins until the very end.
Right.
And I think we set up students for failure by doing that.
Well, and, I agree with you wholeheartedly. I mean, we could take a Fred the head and an IV arm and some pillows and put them on a bed, and we could give a full-on cardiac arrest scenario that needs to be intubated, needs to have an IV started, and never once turn on a mannequin, right? But we could get the whole point across just by having those things there, or maybe a CPR mannequin with an airway head on them or something to that effect, right? So the fidelity of the mannequin truly does come into the user of the mannequin, not to the student, which is why I will always advocate for certifications in simulation. I'm dual certified. I hold the certified healthcare simulation educator, and I hold the certified healthcare simulation operations specialist. Basically, what those two certifications together mean, I know how to design a scenario and I know how to program a scenario into a computer and run the scenario, right? And we need both people to run a true high fidelity scenario. But you're absolutely right. The next thing that we need is we need to teach the user the differences in the mannequins and what the mannequins can do and what they can't do. I'm sure you've been in a scenario, and I've seen it too many times, and I know I was involved in a scenario where the agency that I was with got this brand new high fidelity, highfalutin. Oh my God, this thing does all kinds of bells and whistles, and we're going to throw you into a scenario. And you walk into the room, and there's Plastic Man laying there in the anatomical position, and his chest is going up and down, and he's making noises, and you're like, in the back of your mind, you're like, oh, this is an exam, but what is this in front of me? Probably more terrifying than seeing your first actual patient as a provider, because you don't, at least you know what a person looks like. You don't know what this thing can do and it can't do. So always advocate for pre-training the learners on the different equipment. And really what that means, and I do it with med students, every year that the new class of med students come in, we go into the sim lab and we do their CPR certification, and we teach them how to do IM injections and give vaccines and so forth. But then when we're finished, I take them over to the high fidelity simulator who I've got turned on, and I let them feel pulses. I let them interact with the mannequin. I let them see the chest rising and falling. I show them where the IV arm is, and I show them where they can take a blood pressure. And I let them name the mannequin for the semester so that I know that they know who they're talking about. And they get the opportunity to interact with this, quite honestly, scary looking piece of machinery. And every once in a while, if you're good while you have the mannequin on and somebody goes to like lift up the pant leg to check the feet, you can hit the "don't touch me" button. And the mannequin will scream out "don't touch me," and then everybody gets a little bit of a laugh, and people start to get a little bit more comfortable with this new piece of equipment. Some of them will turn blue. How do they turn blue? They have little LED lights in their cheeks. Some of them have them inside the mouth. So all of a sudden their teeth turn blue. Well, if you didn't know that that was cyanosis, you'd be pointing it out going, what's wrong with this thing, right? So you have to teach them, when you see this, your patient is becoming cyanotic. So they can now associate the cyanosis with what they know cyanosis to look like. So absolutely, you need an operator who knows how to work the equipment, and you need learners who understand what the equipment can and cannot do. Two very important pieces of the puzzle when you're talking about high fidelity simulation. And I love how you put it is, the most expensive mannequin can be a low fidelity simulator if you don't know how to operate it. And that's absolutely true.
So we bring them in. So we've designed our scenario. We've got the objectives. We've tested the scenario for validation purposes. The students going through everything. They kind of hit a couple of points. Should we stop now during formative?
Okay.
Should we stop a learner as they're making mistakes so they don't make those mistakes, or should we let them make those mistakes and then debrief them in the end?
So that the answer to that is completely different, whether it's a formative simulation or a summative.
Right, which is why I clarified for formative.
So in a formative simulation, if they're going to make an egregious mistake, it's better to pause the scenario, talk with them about what they're about to do. And I'll use this as an example. You've got a bradycardic patient. We'll call it a stable bradycardia. Doesn't matter what the cardiac rhythm is. And they're like, I want to give the drug that starts with A. I can't remember. Oh, that's right. It's adenosine. I want to give adenosine to this patient. Okay. It's obviously not adenosine. So how do we as the educator handle it? Well, if they give adenosine, what's going to happen to the patient? The patient's going to go into cardiac arrest, right? Do we want the scenario in a formative to go down the path of them doing CPR for the next 4 minutes? Not necessarily. So I would stop the scenario there and go, okay, let's review your A drugs for a minute. What are the ones that you can remember? Well, there's adenosine and there's amiodarone. Okay. What does adenosine work on? What does amiodarone work on? Okay. Then what's the third one? Atropine. What does atropine work on? Oh, that's the one for bradycardia. I want to give atropine. Okay, now let's restart the scenario. Let's go ahead and give your atropine. Okay. Afterwards, we're going to discuss it. Informally, we'll have a meeting, like a little huddle about how the scenario went and the things that they should work on. Now, if it were a summative scenario, if they go to give adenosine to that bradycardic patient in a summative scenario, well, then the patient goes into cardiac arrest, right? Because they gave the wrong medication. They gave a medication that it is designed to create an asystolic pause. So they are going to create that. And as a result, they are going to do CPR for a couple of minutes. And if they do our agency's protocol or ACLS protocol, and they give epinephrine to the PEA arrest and they don't defibrillate, after 2 or 4 minutes, they can get pulses back and go back to the bradycardia, which would now be an unstable bradycardia. So they should probably do transcutaneous pacing. And then they can still get out of the scenario, but we are going to do a formal debriefing on that scenario. And I say formal because there are about a dozen different ways to hold a debriefing session, and every one of them has names like Plus Delta or Advocacy Inquiry and things like that. But we're going to hold a formal debriefing, and in that debriefing, several things have to happen. First off, that debriefing time should be at least the same amount of time that they ran the scenario. So if they ran a 20-minute scenario, they should have at least 20 minutes of debriefing time. And in that debriefing time, the learner we have to give them time to react to the scenario. Okay. This is a tricky one though, because we're not sure how they're going to react. Okay. They had a patient that was in bradycardia that went into cardiac arrest and they managed to get back, but they were in worse shape than when they started. So sometimes that comes with tears. And to be perfectly honest, that's okay, right? It's when they start throwing things and they get very angry that we have to be very careful and decide, is now the time to debrief or not? So we have to give them a time to react. We have to discuss the actual scenario. And this is the time where we give them the objectives of the scenario. Because in the discussion, we're going to talk about, you were given a bradycardic patient that we wanted you to give atropine to. You had a bradycardic patient, you gave adenosine. As a result, the patient coded. You then had an unstable bradycardic patient that you were successfully transcutaneously pacing on the way to the hospital. We then have to give the learner time to analyze it and reflect on it. And the reflection on it is the part that takes the most amount of time, because we all reflect on things a little bit different. So if you were angry when you walked out of the scenario, it may take you days to reflect on it to realize where you made your first mistake. If you were upset that you killed the patient, even though you got them back, your reflection will come a little bit faster because you're thinking of, how could I have done this better? But the debriefing needs to at least have those 4 components to it for it to be a successful debriefing. And like I said, there's a bunch of different methods to it. I actually have we could spend another 2 hours talking about debriefing, but maybe we'll do that on another podcast.
Yeah. And I mean, the big thing is there's a lot with debriefing that we could talk about. And I think we can get into more later, but how much time did you say we should set aside for the debriefing?
At least 50%.
Yeah.
So for every 10 minutes of scenario gets 10 minutes of debriefing.
Okay. Um, so at the same time, when we're debriefing, there's one more thing that I think we should have learners to do, and this helps with other things. Document the scenario, document the call.
Mm-hmm.
Um, and I think we should do that with software that's similar to what they're going to be using in the field. And I'm not throwing daggers or shooting at any of the vendors right now that are out there that provide stuff for educational facilities, but none of you meet the current thing that people use, whether it's what is it, Angel, ESO, Image Trend, or any of those to document a call report. So, as an agency, we have that luxury to get the people to document the call. But students in the classroom need to learn how to document, because when they get to the field, we're like, no, you're still using paper methods for charting. But that's another podcast.
Right. But I mean, if you're using the FSTEP process and you're running your new people through an academy, when I was with Durham, we had psychiatric day where they saw 4 psychiatric patients. You know what the
Mhm.
day after that should be? Write them all up. Every single one of them should be documented. You should be taking notes the whole time so that you can write them up. And you're absolutely correct. To my knowledge, there may be one or two out there, and I'm not gonna like you. I'm not gonna say anything bad about these vendors, but I think every one of them who sells a software platform should have a backdoor option where we could generate charts that never go through and are never saved in the actual system. Call it a training database, call it a ghost database. They should have some kind of database so that our IT people can build new things and our training people can write up charts. It's the same issue that I'm running into with medical students and with residents when we do training. They call it writing a note, right?
Mhm.
We call it writing a chart. They call it writing a note, but they don't get to write a note on their training. They do their training and then they go back to their to see their patients. We should have everybody should be writing up every training that they do, and we should be following up with them on what they wrote up, because you'd be amazed to find the things that people don't put in their narratives because they just simply forgot. And to be fair, I mean, you have 2 people in somebody's house trying to do, 500 different things. Sometimes they do get forgotten, but,
Right.
but if you don't know what the important things to write are, and you don't know what the unimportant things are, and you don't practice it, you'll never get better at it. And I hear it from our billing side all the time. You know, billing goes crazy over some of the stuff that we put in charts. Imagine if we could actually spend a week just learning how to write a chart.
Right. And just like we, from scenarios in classroom, if we learn a document there, it'll translate to good practice in the field, because you don't want to put anything in the narrative that you can use in a drop down, but
Right.
for data purposes and everything else.
Right.
So I think the information that we've talked about tonight will give people a good start to look at how they're doing their scenarios. We're going to have a few show notes and a couple other things, but begin with writing that objective. Make sure it's a smart objective that you're specific with what you want to test. You can have a couple of those on there, but specifically want to test. Make sure it's measurable. How you're going to measure that. Make sure it's going to be
The two
achievable.
keys to it, the two real keys to the SMART objectives, I don't mean to cut you off. They
Oh,
have to be obtainable and they have to be measurable, right?
mm,
Those are the absolute 2 most important in that whole thing. Yes, they have to be specific, but they absolutely have to be attainable and measurable. Sorry, go ahead.
no, and they've got to be relevant. Realistic and relevant. Because
Mhm.
if you give somebody an unrealistic scenario, they're not learning anything.
And
Um,
what you're teaching them to do is to be afraid of simulation, to be afraid of education. Because if you're gonna throw curveballs at them all day long, eventually they're gonna stop coming in for training. And those are the people, and you can see them at every agency. You'll see them. They're the ones who get flagged down on a call when they're on their way to their training session, or they overslept and forgot that they had training that day. Those are the people who are afraid because we've done that to them.
So I think we can take the information we've talked about. I think we can build better scenarios. And I encourage people to reach out and to be able to look at this, build a group of people, a group of instructors that can work to validate the scenarios. If you wanted to tell somebody a book or a class or anything that they could go take to learn how to better do scenarios, what would it be?
I think it would be the Certified Healthcare Simulation Educator course. They can go through the course. It's through the Society for Simulation in Healthcare. It is truly designed at the educator level for you to learn how to run simulation as a whole. And it is a bit expensive. Some things unfortunately are. It does require that you have a little bit of experience working with other simulators. I think other simulation teams. So I think they require 2 years experience before you can become certified. But I'll tell you, having been involved in simulation since I guess around 2010 when I first started, I became a certified healthcare simulation educator 8 years ago, 7 years ago now. And going through the process, I learned so much more. I learned all of the things that I was doing wrong, and I learned things that I didn't even know that I wasn't doing. And I think that's one of the best courses out there.
Yeah. Even though it is a little, they're a little pricey, but they're well worth it.
Yeah.
So
the certification exam was $375.
Right.
Yeah. So not as pricey as some other things out there, but training courses are around $175. The books are about $60 or $70. So all told, a good couple $100 to get involved. But like I said, it teaches you from an education standpoint. It doesn't care whether you're an EMT, a paramedic, a nurse, a physician, or a school teacher. It teaches from every level, and I think it's absolutely worth it.
All right. So, any other final thoughts? We've been going back and forth now for about about 55 minutes. So
okay. So really, the one thing, if I could just tell everyone out there who gets involved in simulation, don't wing it. Don't do anything on the fly. Build scenarios based on your objectives, test them, and let your learners win the scenarios. If you build a good scenario and you have a good team of people going through, most of them are going to win the scenario. And celebrate their win and work with the ones who don't. Because I think old school EMS was designed around eating our young. And we have to, first off, we have a new generation of people out there who don't understand the hardships that we went through. I think we have good people who leave EMS because our education system drives them away. I think if we really do create a good, solid set of objectives and meet the objectives, I think you could turn your education around and you could have a bunch of people who just want more education. And we could literally change the whole society in EMS.
and I think so too. So, with that being said, how can people reach out to you if they want more information?
I will give you my email address, but I have a couple.
Okay.
They can reach me at jslattery3498 @gmail. That's my personal professional email address, or joseph.slattery @hcahealthcare.com. or if somebody wants to give me a call or shoot me a text message, phone number 772-828-9708. And that phone's always on.
All right. So,
Unfortunately.
so if anybody out there wants to reach out to David or I, if you've got information, or if you looking for stuff, or you've got an idea for the podcast, please feel free to reach out to us. You can find us on Facebook, LinkedIn, Twitter. We are also on Snapchat, but the easiest way is through our email, which is bradley.dean@handoffmedia.com or david.blevins@handoffmedia.com. Thanks for joining us for another episode of the EMS Handoff. We're just trying to give you a little information on healthcare simulation. Again, we'd like to thank our healthcare partners and GEMS for supporting us on their platform. And for all the people in the western part of North Carolina, eastern part of Tennessee, Virginia, South Carolina, Georgia, and Florida that have had all the recent disasters, everybody's in our thoughts and prayers. Take care, and we'll see you soon on the next episode of the EMS Handoff.